Good afternoon, everyone. My name is Leila Otieno, and I have my partner here, Mr. Andy Rimando. We are going to present our case on thoracotomy. We have our patient here, Mr. Dewey, and I'll talk a little bit about him. He's going to have thoracotomy. His pre-admitting diagnosis is left lung cancer, and he will have thoracotomy today for lung resection. He is a 50-year-old male. He has no allergies, and he has a history of appendectomy, right lung cancer. He's started post chemo about the last dose was about 2 weeks ago. He is on he's not on any medications currently other than Motrin PRN, and his last chemo he had methotrexate. I forgot the patient is 70 kg. He's 70 inches tall, BMI of 22.
Okay, so if we're gonna do so this is basically a thoracotomy. So this is a timeout. All right, we're gonna do a left thoracotomy on this patient. All right, ANSEP is given. It's infusing 2 grams. Thoracotomy basically is a procedure where you open the pleural space so the doctors or the surgeon could actually visualize and do the procedure. So most of these patients normally they have malignancies. They got cancer, lung cancer. In his case, he got a left lung cancer. All right, and then thoracotomy basically is a procedure where you open the pleural space so the doctors or the surgeon could actually visualize and do the procedure. So most of these patients normally they have malignancies. They got cancer, lung cancer. In his case, he got a left lung cancer. All right, and then issues. They are smokers. And usually they are like 40-year-olds, like middle age. Okay, and generally in this kind of procedure, post-op pain is really, a big issue for them. Okay.
So the other thing is that I just wanted to let you know that the patient was pre-medicated in the holding room. He was given 2 milligrams of Vancid IV. He's a young guy. He seemed a little bit nervous, so that was indicated. The other thing I wanted to let you know is that patients who have vascular pulmonary issues, so we need to take all that into consideration.
Okay, so like Leila said, pre-op, we're gonna give him antibiotics. So there's IV, ANSEP, maybe 1 to 2 grams, and then, or if they're allergic to that, we could get clindamycin, which is 900 milligrams. We will give them Versed also, 2 grams, 2 to 4 milligrams, sorry. And then Robinol to dry up the secretions, about 0.2 milligrams. Usually we preload the Zofran, 4 milligrams, and Decadron, about 8 milligrams on this patient. Okay, so
some patients may have secretions. We could either give mucomist, pre-medicated mucomist, or potassium iodide if the patient had viscous secretions. And so those are some of our options. Another option to help loosen the secretion is prehydrate the patient, which can help thin the secretions and facilitate removal. And then you can talk about
pre-op. Yeah.
You can talk about the special equipment.
Okay, so the special equipment, even before the patient comes in, there's a lot of preparation to this case. First of all, you need retractors on this, trocars. Also, you're gonna need, you need arterial line, okay? You could either put that intraoperatively or preoperatively. Some of them you need probably TEE, okay? You're gonna need, for positioning, you need axillary rolls, you need pillows, you need bear huggers, fluid warmers, and then most important of all is the double lumen tube, or else you won't be able to do this case.
The A-line
Yes.
is definitely necessary. The CVP, the PA catheter lines, those are kind of optional. It just depends on the situation. I don't think we're going to need them in this situation, but we're going to verbalize that we do need an arterial line. And the next thing we're going to talk about is, you want to talk about
The preoperative.
preoperative.
So preoperative, all patients, you have to do physical examination on this patient, right? Everybody. You want to know their basic pulmonary function testing, all right? Also, physical examination, breath sounds. What are the breath sounds? Are they wheezing? Are they, having rails or wheezing, crackles? That sort of thing. You gotta look, listen to their heart preoperatively. Their murmurs, or there any cardiac abnormalities. And also exercise tolerance, all right? That's very important. Can they go up a flight of stairs? Also, you're going to need all the labs. You're going to need your CBC, your chemistry, electrolytes. You're going to need your coagulation studies, PT, PTT, all right? And you're going to need the type and cross on this patient because the projected EBL is between 200 to 1,000 mL. All right, so you're going to need to type cross them to 2 units of PRBC, okay?
And the other things for preoperatively, forgive me. We can also discuss issues such as pain, post-op pain management in the patient. We have tried to introduce some of the ways we're going to manage the pain. As we said earlier, the procedure is very painful. And then if the patient has lung cancer, like our patient here, we need to take into consideration if this patient can tolerate this procedure. If the patient, we're going to look at the mass effect of the cancer. We're going to look at metabolic effects of the cancer, and metastasis. If the patient has COPD, we are going to be concerned about the ABGs pre-op so that we can have a baseline. We're going to worry about secretions. We're going to worry about whether the patient, we're going to be concerned about if the patient had bronchodilators as part of his regimen, or if he needs some.
And also, one of the most important thing is you have to have like your FEV1. Because normally, if your FEV is below 40%, that puts the patient on high risk. At this point, this patient only has 60%. So he's above the 40%, so basically he has like a medium risk.
And then the other test, he has a medium risk. If the patient has less than 40 FEV1, then we are looking at serious possibility of serious post-op complications or intra-op complications, including death, and we're also going to be concerned if the FEV1 is less than 40, the patient may need ventilatory support post-op. The other test that also we need to look at is diffusing capacity of carbon monoxide. If it is below 60, then we know that the patient is a surgical risk, and below 40, we know that the patient is already a high risk. The other things we can look in the chart at pulmonary function test. We can look at the CAT scan results, ECG, the most recent ECG. We can look at the most recent chest X-ray, TEE, echo results, cardiovascular, any kind of cardiovascular test, and other types of tests. And we also need to ensure that the patient is pre-op. We take care of hypovolemia. We take care of any electrolyte imbalances.
Yes.
So we're going to look at the labs.
Mm-hmm.
If the patient has renal issues, we're going to focus on BUN and creatinine. Other labs to look at hematology, chemistry, albumin, and like we said, pre-op ABGs, and pretty much just, yeah.
Okay. And I would like to add, like I said earlier, post-op pain is really important on this, and also intraoperatively. So maybe in the pre-op, they could actually put an epidural on this patient, all right? And so, that basically lessens the requirement for narcotics on this patient, so, and that's important.
So for the regional block, one of the possibilities is a thoracic epidural, and with that, it helps limit the intra-op pain and the post-op pain. And what we can use for what they usually use for that is they can use a Marcaine 0.25%, 7 mils of Marcaine 0.25%. That is about 2.5 milligrams per mils, combined with either Astromorph or Duraloff, 3 milligrams. And what we can do is post-induction, right before the incision, we can give a bolus. And just be able to observe the sympathetic response during the incision. If there is no sympathetic response, then we know that the initial bolus worked. Now, different literature say different things. Either you can continue with boluses every 30 minutes, anywhere from 1 to 3 cc's bolus through the epidural, or you can give every 1 hour 1 to 3 cc's of that combination.
So now the patient is here, okay, and we're going to do the induction. So basically, you start the patient supine, all right? So we transfer the patient from the stretcher to here, all right, and now he's here. And Bela, we're going to do the induction.
Okay, so the other thing that I'd like to point out is that the variant procedure. This procedure can either be approached through axillary, median, posterolateral, and anterolateral. In our case today, the patient is going to be approached posterolateral, so we're going to have to place the patient in a lateral decubitus position. So right now, like I said, we already pre-medicated the patient in the holding room with our VASID. So what we're going to do right now is we're going to speak to explain to Mr. Dooley that the induction plan is going to be standard. So I am going to explain what we're going to give him before, for the viewer's benefit. My induction plan today is general anesthesia. You can have general anesthesia without the epidural or with epidural, but you can also have TIVA as an alternative to general anesthesia with tracheal intubation. So our plan is general anesthesia with tracheal intubation.
Let's go ahead.
So we're going to go ahead.
All right.
First of all,
so what we're going to do first is, once the patient is in the table, we're going to hook up the monitor. Okay, we're going to hook up the blood pressure cuff, all right, and tell the patient that it's going to be tight, all right, initially, all right, because that's what they contain initially, all right. And then we're going to put the pulse oximeter, all right.
So the pulse oximeter.
It's the first one, sorry.
So I'm going to put the pulse oximeter on the hand with the IV, and then we'll place the
blood pressure on the other side,
on
right.
the
Other arm.
Yeah, and then run the blood, cycle the blood pressure, and then we put in the monitors, and then we will.
And then we're going to pre-oxygenate the patient 100%, all right?
Yeah. 10.
All right.
Okay, so now we are pre.
So now, we're oxygenating the patient.
Okay, so Mr. Judy, we're going to go ahead and give you some medicine to take you to sleep, okay? All right. So I'll bring my medications. Remember, my medications were prepared beforehand. I have my induction medications and I have my emergency medications, okay? All right, so this is the IV over here. All right. So Mr. Judy, I'm going to go ahead and give you some medicine to put you to sleep, okay? I'm going to give my lidocaine, 80 milligrams. It's going to be followed by fentanyl. Okay. It's going to be followed by... Yeah. So I'll give my lidocaine and then I'm going to give my fentanyl, 150 mics. I will follow that with propofol, 150 mics. I am going to observe for effect. Mr. Judy, how are you doing, Mr. Judy? Mr. Judy is still not asleep. Okay,
Keep your eyes open.
Okay, can you open your eyes for us? So just want to wait for the Mr. Judy to sleep. Mr. Judy, can you open your eyes? Mr. Judy is now asleep. I'm going to check for eye reflex, and he doesn't have any eye reflex.
Okay,
so
now we're going to take the eyes
we're going to take the
gently.
eyes, and I'm going to go ahead and give my succinylcholine. Okay? So I will give my succinylcholine, and then we're going to try to attempt positive pressure ventilation.
So now the succession, the anectin is on board, all right? We're gonna try to manually ventilate the patient, all right?
And we will be observing for circulation.
And yeah, and we see that there's like bilateral chest rise, okay? Okay, we got CO2 on the monitor also.
And we have the listing around the mask, so we know that we are ventilating well. And the stats on the monitor 100%.
Okay.
So we know that we can. So
easy ventilation on this patient. All right. Now we're gonna attempt to intubate the patient. All right. Okay. We got 100%.
So do you want to explain?
Yeah. So we're gonna intubate the patient with a double-lumen tube. All right. So this first, we're gonna use a Mac blade. All right. So gently. Okay. Make sure you don't, you see the vallicula, you see the epiglottis, all right? So you could go ahead. With this, with double-lumen tube, you has to make sure that it's tip up, all right? Okay, I'm just going to simulate this, all right? So, tip up. If you see, visualize the vocal cords, all right? Go ahead, and then once there, you could remove the stylet, all right? And then you could advance it, all right? All right. And then once you advance it, you could turn it 90 degrees. Don't remove your Mac blade yet, all right? You have to visualize that you turned it, all right? So I think we got a good position, all right? And then slowly, I'm gonna remove this, all right? And then you're gonna do the tracheal cuff first, all right? And then we're gonna use for this DLT, we're gonna use the adapter, all right? Oh, no, not yet. All right. So what we're gonna do, is gonna ventilate the patient. All right. So I see bilateral chest rise. We see the mist, all right? And you see the CO2 going on there.
We're gonna have a stethoscope. I'm gonna go ahead and listen.
All right. So at this point, we're still ventilating bilaterally. All right. Tape it. All right.
So once we confirm placement, we have to turn.
Right.
We're gonna.
So just tape it for now. Okay.
We're gonna go ahead and we're gonna turn on the vent. We're going to go down on the flows slightly.
Go on the flows, right?
And then we're going to turn on the gas. We're gonna turn on to about 2 mics. And then we will turn off. We will open the APO valve.
Right.
And then I'm gonna recycle the blood pressure. And then we can go ahead and tape.
Okay.
Okay.
Now, since this is the double-lumen tube, all right, what we could do is try to isolate each lung, all right? First, you clamp the left side for the left tube, the bronchial tube, all right? And you could listen to the lungs, basically, all right? And see whether there's you could hear breath sounds on the right side, all right? And then you listen to here, there shouldn't be any breath sounds on the left because you clamp the left tube, all right? And the same goes with the right tube, all right? So you clamp the right, all right? Listen to here, okay? And you should hear breath sounds on the left and absence on the right. And then you could remove the clamp, all right? Now, for real verification, you would use a fiber optic tube, all right? So what they do basically is insert the fiber optic tube on the tracheal tube, basically, and then advance it, all right? And then at the tip, you could actually see the carina, the bifurcation, all right? The best way to verify it, if you could see the left carina or the left bronchial tube, basically it's occluded by the blue balloon. And now you're golden. this is actually the gold standard of verification.
Normally this would happen very quickly, but because we're explaining, so we are taking a little bit
Too much time, right?
So once we have a placement, what the next thing to do is, because we're going to paralyze the patient, I would attach my leads, touch my leads and place my nerve stimulator to check for twitches. And if the patient has return of twitches, then we're going to go ahead and give the patient rocuronium, and like I said, 40 milligrams of rocuronium. So the other thing that we're going to do, I will be observing my vital signs on the monitor over here, make sure that my vital signs remain okay, and then I'm going to apply my beads. I'm going to go ahead and apply my, the temperature probe, either axillary, and then I'm going to go ahead and apply my warmers. It's very important to warm the patient, and we're going to warm halfway down the body.
Are we positioning?
So we have, with lateral positioning, we can have issues like nerve injury. We are looking at brachial plexus that can be injured through stretching, compression, and traction. But the biggest culprit here is stretching, and compression is a secondary cause of brachial plexus injury. So we can also have injuries to ulnar, to radial, the sciatic nerve, and the intrathoracic nerve injuries through during the surgical procedure. The other issue that we can have with positioning is reduced functional residual capacity because of the positioning itself, because of the patient's comorbidities. We can also have the anesthesia, general anesthesia also reduces functional residual capacity. The other thing we can, the other problem is circulation. Remember, when you place the axillary roll, if you don't place it properly, it can cut off circulation to the arm. It's supposed to be placed slightly corded to the axillary so that it doesn't cut off circulation. One of the ways that you can do once the position is, check the carpal field, temperature, color of the fingers, and also you need to place the pulse ox on that dependent arm so that, and also check the pulse just to make sure that the circulation is not cut off.
Okay. So once they prep the patient and all that, so what are the complications of having a lateral decubitus? So what is being mismatched?
Now, normally if we place the patient on a lateral position, we expect to have, if the patient is, our patient in this case is anesthetized, and the patient is anesthetized and paralyzed, so there will be some VQ mismatch. The dependent lung is going to have more perfusion and less ventilation, and the non-dependent lung is going to have less perfusion and more ventilation. In this case, the situation is going to be exacerbated by the fact that the non-dependent lung is going to be deflated. So that we have to take that into consideration. Okay. So the other thing, the next thing we're going to talk about is maintenance. Now that the patient is on the vent, so as we are doing all these things, we will be monitoring the patient's vital signs. Remember, up until now, the patient is having 2 lungs being ventilated. Now, we, according to the patient's weight, 550 tidal volume is sufficient. Rate of 12, people of about 5, and the patient is on volume control. Once they make the incision, we're going to look for sympathetic response. If the patient needs more medication, obviously we'll give more fentanyl or deepen anesthesia or whatever it is that we want to do.
And I want to add also that this is the good time to basically bolus the patient with epidural.
Yeah, like we said earlier on, we can give a bolus of the epidural right before the incision. Now, after the incision is done, there's no sympathetic response. We know that it worked. The next thing that we're going to do is maintenance. I wanted to point out that SIVO is being recommended for this procedure only because many of these patients happen to be smokers, COPDs. The airway is easily irritated. So we're going to be using SIVO. Once the patient, the doctor makes incision, we're going to now we're going to the next step, which is 1 lung ventilation.
Okay. To achieve that, basically you need a suction and a clamp. All right. So the surgeon will ask you drop the lung. All right. So what you're going to do with that? So we're going to operate on the left lung. All right. So clamp the left. All right. And then basically what you're going to do is suction the air contents of the left lung. All right? Okay. So now I'm going to suction the air. All right? And right now we're doing one lung ventilation. Okay.
Now, once the lung is dropped, we will change our ventilator settings from a volume control to PCV, so that we can be able to maintain the pressures that we want to maintain. So we are looking at we're going to convert, we're going to change our ventilator settings to pressure control volume. We're going to make sure that the PAPs stay below 35, and we're going to make sure that our Pmax does not go beyond 40, which is a risk for barotrauma. And we're going to maintain that for as long as we're going to increase the FiO2 to 100% oxygen, and we're going to maintain that for as long as the patient is under one lung ventilation.
Now, during the one lung ventilation, you might encounter that the patient could be hypoxic. CPAP, all right? So you're going to use this. You're going to put this on the auxiliary oxygen.
20 to 5.
Yeah.
Around 5.
So we're on 5, and then we're going to connect this to the 1, all right? And to the 1 will be the lung being operated. So basically, it's anywhere between 5 to 10 centimeters of water, all right, to insufflate it. Okay. So basically, we're insufflating it, all right? And also, this helps also with, say, during one lung ventilation, and you encounter the VQ mismatch, and you become hypoxic. What you could do basically is you could give him CPAP on the operative lung. All right, hypoxic, you could do recruitment maneuvers on this patient. All right, by holding during expiration, you could just hold it for like 10 seconds, and then release it again. So until you basically recruit the lungs, recruit this alveoli for oxygenation.
Okay, so that's well said, and the recruitment maneuvers can continue. They can be intermittent during the procedure, and all this is in an effort to be able to prevent hypoxemia during the procedure because of the VQ mismatch. Okay. Now, the next thing we're going to talk about is the monitoring. We're going to use standard monitoring. We're going to we talked about an airline, which is necessary in our situation. We are not going to use a CVP and a PA line. And also at this point, we have the patient needs a Foley, so we're going to be monitoring output. And we're going to talk about fluid and electrolytes at this particular point. The patient has 2 peripheral IVs, large 18 gauge and 16 gauge on both arms. We need normal saline or LR. We're using LR lactated ringers at this point. The thing is, when we calculated our fluid deficit with a 70 kg weight and the NPO of 10 hours, we're looking at around 1100 deficit. We're going to make sure that we hydrate the patient without having to fluid overload the patient. The other thing is the EBL for this procedure is anywhere from 200 to 1000, and we do have our type and cross in case we need that. The other thing is the literature says maintain the patient at a stable hypovolemia. And we do have our vasopressors waiting, ephedrine and neo in case neosymethrin in case we need them, and we are also going to diligently monitor for urine output. And then for emergence, now when the surgeon is just about to close is approaching closure, what we're going to do is we're going to reinflate the surgical lung gradually to make it attain a pressure of 20 to 30 centimeters of water, and so this one is to prevent damage to that surgical lung. Okay, and also to allow the
atelectasis.
The lung, the atelectac, lungs to kind of get
recruit itself, right.
to get recruited. And then also the surgeon is going to place a chest tube in the patient. He's going to want to know if you're losing any volume. So you need to be able to know how much tidal volume you're on. So for instance, if you're on 700 mils, then and you're only getting about 300 mils of volume, then you probably know that you're losing about 400. But it's going to get better once this chest tube is connected to suction. Okay. The patient also need for a patient. The plan is to extubate the patient in the OR. So we need to extubate the patient when the head of the table, the head of the bed is elevated or in a semi-fowler position. So if you have an OR bed that you can actually raise the bed. Now, before we even think about extubation, once the lung has been expanded, the surgical lung, then you can go back to your previous setting. So for us, we were on pressure control. We're going to go back to volume control or whatever settings you were on before, and then we will. And then chest tube is going to be inserted. We know that we're going to be ventilating 2 lungs instead of 1. And for extubation, OR is preferable in a semi-fowler position. So one of the things they can do is raise the head, if possible, or raise the head of the OR table, or you can actually transfer the patient onto a stretcher, put it on a semi-fowler position, and then extubate the patient at that particular time. So for post-op care, what
I'm going to discuss the extubation.
Okay.
Extubation first. So of course, we want to extubate the patient, in the OR, all right? But in case that you cannot, the surgeon prefers that the patient remains in ICU because of respiratory compromise, you could actually change the double-lumen tube with a standard single-lumen tube, right? And if the patient meets the parameters, then we could extubate.
If the patient does not meet all these parameters, then obviously, like you said, change to single lumen, transfer the patient to ICU. Now, for the post-op care, we're going to make sure that we have an X-ray, chest X-ray to ensure placement of the chest tube. Also, we're going to be monitoring for post-op complications, and we're going to talk about them in just a little bit. Also, we're going to check for neurological issues, such as if you need something like phrenic nerve or the laryngeal nerve, then we are looking at an airway emergency. If you need any intrathoracic nerve, then we're looking at complications. The other thing is the disposition for this patient usually is to ICU, and we're going to be monitoring, we're going to be concerned about pulmonary toiletry and the chest tube output. And the last thing is post-op pain management, which is the pain is profound. So we're going to make sure that the patient's pain is management. We can do that through the epidural that we put in. If there was an intercostal block, that would help. Or we can do the IV opioids or PCA and SAIDs. Okay.
So what are the post-op complications for this patient? Of course, DVT. All surgical patients are have that complication. You're gonna have nerve damage, maybe. So you gotta watch out, because in this kind of procedure, your recurrent laryngeal nerve, your phrenic nerve could be damaged. You could have hypocarbia during the procedure, hypercarbia. You could have hypoxia. You could have hypotension. That's why it's important to preload them with fluids. You could actually have trauma, because we're using a bigger tube. All right, so you could actually damage the trachea. Infection also is it's a big problem.
Bleeding.
And bleeding.
Airway vocal cord damage, airway rupture, and damage around the surrounding tissues of the airway too. Now, the other thing is ways that we can minimize those risks. We just make sure that we avoid fluid overload. We can ensure to minimize the risk. We can make sure that we keep the tidal volumes low and the peak pressures low, plateau pressure is low, and then we can also make sure that we, literature says that the best way to avoid atelectasis is low tidal volume and low PEEP around 5. Yeah.
All right.
And we're trying to think if there's anything else that we can say.
Mortality is around 1 to 5%, this kind of procedure. Morbidity, I already told you, complications. So like I said, you know, you could have bleeding, you could have hypoxia and hypercarbia, you know, that sort of thing. So.
And also for other additional issues, these types of patients, they're prone to hypothermia because we're opening up the chest. So we have to make sure that other than the bear hugger, we have to warm the fluids. And for the what do you call it, the one lung ventilation, we have to be vigilant in terms of keeping the ventilatory parameters within the evidence-based level.
Okay. All right. Thank you so much for listening.
Very good.